Good morning, and welcome to day 2 of this public meeting of the Physician-Focused Payment Model Technical Advisory Committee, known as PTAC. I am Lauran Hardin, the Vice Chair of PTAC. Thank you for tuning in. I would like to welcome Dr. Liz Fowler, who's the Deputy Administrator of the Centers for Medicare and Medicaid Services and Director of the Center for Medicare and Medicaid Innovation. Dr. Fowler previously served as Executive Vice President of Programs at the Commonwealth Fund and Vice President for Global Health Policy at Johnson & Johnson. She was Special Assistant to President Obama on Healthcare and Economic Policy at the National Economic Council. From 2008 to 2010, she also served as Chief Health Counsel to the Senate Finance Committee Chair, where she played a critical role in developing the Senate version of the Affordable Care Act. Welcome, Liz.
Thank you so much, Dr. Hardin, and good morning, everyone. I'm really delighted to be here with members of the PTAC and everyone participating in this day 2 of the PTAC June 2022 public meeting. I'm so glad to be here in person today and to be able to join you. The CMS Innovation Center's vision is a health system that achieves equitable outcomes through high-quality, affordable, patient-centered care. We very much appreciate the partnership and collaboration of PTAC as we strive to meet the ambitious goals embedded in this vision. I think many of you are already familiar with the strategy that CMMI issued last fall, but as you continue the discussion today on population-based total cost of care models, I thought it might be helpful to reiterate the 5 strategic objectives that guide and prioritize our work and tell you what we've been doing to try to reach our goals. So if you'll indulge me for a little, as our first objective, as part of this strategy, we've put an emphasis on driving an accountable care, and that means focusing on payment and performance incentives and models, and especially in total cost of care models for specialty and primary care providers to coordinate delivery of high-value care and reduce duplicative and low-value care. We set an ambitious goal to have all Medicare beneficiaries and a vast majority of Medicaid beneficiaries in a care relationship with accountability and quality and total cost by 2030. This means an ACO, advanced primary care, or Medicare Advantage, although I think we don't automatically assume that MA plans are paying based on value. As we understand it, many of them may receive capitation but still pay providers based on fee-for-service. In February, we announced changes to the CMS Innovation Center's global and professional direct contracting model and the transition to a new ACO REACH model. And the design of REACH has laid a lot of the groundwork for our thinking in terms of how to advance equity. And the model can also be critical to reaching our accountable care goals. Medicare Shared Savings Program and our ACO programs at the Innovation Center need to work together. And with our colleagues at the Center for Medicare, we published a piece in the New England Journal of Medicine last month that speaks to our shared vision of testing certain aspects of new Innovation Center ACO models that will inform the MSSP program. We're working to design our models to provide higher quality, better coordinated care at the same or lower cost to Medicare beneficiaries. And we aim to put the patient at the center of the care team that provides high-value, equitable, evidence-based care while holding providers accountable. We look forward to learning more from PTAC and the speakers from the June public meeting to help inform our work on this objective. I was fortunate to be able to meet with the PTAC members in an executive session to learn more about what happened yesterday and a lot of the lessons from the speakers. I unfortunately had to miss yesterday's meeting due to another conflict. Our second objective is advancing health equity. We're committed to embedding health equity into all aspects of our payment and service delivery models. And central to this work, if you look at our models launched to date, we have not necessarily been representative of patients in low-income, Hispanic, and rural communities. And we want to use all available levers to ensure equitable access to the innovations we're testing. Is that my microphone? No. All right. We're working to design models to increase participation among providers that care for underserved populations and close disparities in care and outcomes. In December, we held a roundtable on our health equity strategy, and in March of this year, Dr. Dora Hughes, who's our Chief Medical Officer, published a paper in Health Affairs that talked about our strategy in a little bit more detail regarding health equity. And then in March, we held a roundtable focused on safety net provider participation in CMS innovation models. I'm interested to hear from your speakers what more we can do to attract these safety net providers in total cost of care models. Objective 3 is related to supporting innovation. What more can we do to support model participants looking for ways to innovate care delivery approaches? That includes actionable data, learning collaboratives, payment flexibilities available to model participants. I heard today from members about the need for really timely data too, to make sure that it actually is influencing decisions. Our fourth objective is affordability, addressing affordability. We have been very laser focused on expenditures in Medicare and Medicaid, but we also want to make sure that our models have an impact on lowering patients' out-of-pocket costs. And we're looking for strategies that target healthcare prices, affordability, and reducing low value and duplicative care. Going forward, we're focusing on payment and performance incentives in models, and especially in total cost of care models for specialty and primary care providers to coordinate delivery of high quality care, and as I said, reduce duplicative or low value care. And then the final is partner to achieve health system transformation. And this is part of, as I think about this goal, it's really around multi-payer alignment, and have heard very loud and clear the need to find ways of engaging commercial payers, working closely with states on Medicaid and other purchasers and others to make sure that we're all aligned and heading in the same direction. It might not need to be as part of a single model, but maybe there are aspects of care where alignment makes the most sense, for example, on quality metrics. We're working towards our 2030 goal for multi-payer payment alignment in all new models, and asking stakeholders like you how we can better align with private payers, purchasers, and states. We're actively engaging stakeholders, leveraging existing and new mechanisms to enhance engagement with patients, providers, and payers, and we want to try to improve transparency in our model design and implementation. We're holding listening sessions with beneficiaries, health equity experts, primary care, I mentioned safety net, specialty providers, states, and payers. And last month, Administrator Chiquita Brooks-LaSure hosted a listening session on dementia care, which is an area of growing interest for the Innovation Center. The Innovation Center will continue to communicate and share our strategy through conferences, podcasts, learning events, and opportunities like the PTAC public meetings. We're excited that the meeting here, the presentations and discussions about population-based total cost of care planned for yesterday and today, focusing on addressing some of the same challenges that we're facing. So maybe in closing, I just want to thank PTAC for their valued work and continued support for healthcare transformation. And also to thank the committee for putting together such a vigorous agenda and an amazing panel of experts. Again, just like the March meeting and the meetings before, I'm consistently impressed with the folks that you have presenting and sharing their perspective. So thanks for your attention, and best wishes for a great second day.
Thank you so much, Liz, for the time this morning and also these very valuable comments. We look forward to continuing to collaborate with you and your team, and you're welcome to stay. There's some really interesting speakers that really connect to the themes that you raised, and hope you get an opportunity to hear them today. So you can move to the seating area if you like, but we also understand if you have a busy schedule and have to go, we'll definitely be sending you the notes.
I'll be dialing in.
Access the video.
But I will be listening. Thank you.
Thank you so much, Liz. I really appreciate your time. So yesterday we had a variety of experts present, from academics and payers to our very own Angelo Sinopoli. They generously offered their experience with care delivery in population-based models. Today we have multiple presenters and panelists ready to share their expertise, followed by a panel discussion. Then we will have a public comment period. Public comments will be limited to 3 minutes each. If you have not registered in advance to give an oral public comment tomorrow, but would like to, please email ptacregistration@norc.org. Again, that's ptacregistration@norc.org. Finally, the committee will have a discussion to shape our comments for the report to the Secretary of HHS that we will issue later after the series concludes. Because we might have some new folks who weren't able to join yesterday, I'd like the committee members to please introduce themselves. Share your name and your organization, and if you would like, you can share a brief word about experience you may have with population-based payment or total cost of care models. I'll start. I'm Lauran Hardin, Senior Advisor for National Healthcare and Housing Advisors, and I've spent the past 20 years either directly delivering value-based payment models and now partnering with states, communities, health systems, and payers to design models for population total cost of care. Paul.
Paul Casal, I'm a cardiologist. I lead population health at New York Presbyterian, Weill Cornell, and Columbia, and also oversee New York Quality Care, which is the MSSP ACO for New York Presbyterian, Weill Cornell, and Columbia.
Hi, I'm Jay Feldstein. I'm the president and CEO of Philadelphia College of Osteopathic Medicine, trained in emergency medicine. And I spent 15 years in the health insurance industry in both commercial and government programs, of a lot of experience in capitated products and risk-sharing relationships.
Good morning, I'm Lee Mills. I'm a family physician, and I'm Senior Vice President and Chief Medical Officer at Community Care Managed Healthcare Plans of Oklahoma, involved in both commercial, Medicare Advantage, and individual exchange space, experience in medical group leadership, operating in MSSP and multiple CMMI value-based models over the years.
Good morning. I'm Walter Lin, founder of Generation Clinical Partners. We are a medical group focused on delivering care to the frail elderly in senior living, particularly nursing homes and assisted living facilities.
Good morning. I'm Angelo Sinopoli. I'm a pulmonary critical care physician by training. I've spent the last 20 years in population health. I've run large integrated networks and have built enablement companies. Presently, I'm the Chief Network Officer for Upstream, which is a company that partners with primary care physicians to enable them to participate in value-based arrangements.
Good morning, Joshua Liao. I'm an internal medicine physician and faculty at the University of Washington. There, I'm also the enterprise medical director for payment strategy, as well as lead a group that does research and evaluation on payment and delivery models, including total cost of care models. And so in those ways, think about how do we translate design and policy evaluation into practice.
Good morning. I'm Jennifer Weiler. I'm the Chief Quality Officer at UC Health's metro area. I'm a tenured professor of emergency medicine at the University of Colorado School of Medicine, and I'm a co-founder of UC Health's Care Innovation Center, where we partner with digital health companies to grow and scale their solutions to improve the value and outcomes of care for patients. I was original co-author of an alternative payment model.
I'm Larry Kaczynski. I am a gastroenterologist and am the founder and chief medical officer of Sonar MD, a company that I founded back in 2016. I've spent the last 10 years of my career focused on value-based care, and I'm happy to report that Sonar was the first PTAC recommended physician-focused payment model back in 2016.
And Bruce, we'd like to ask you to introduce yourself from Zoom.
I'm Bruce Steinwald. I'm a health economist in Washington, D.C., although right now I'm in Massachusetts. And this is my 7th year as a member of PTAC.
Thank you so much, committee members. As you can see, we have a tremendous wealth of experience and expertise on the panel. So at this time, I'm very excited to welcome our third listening session for this 2-day public meeting. Paul, would you please come forward and join the table? We've invited 3 outside experts to give short presentations based on their experience, and then our committee members will be able to ask questions. You can find our speakers' full biographies on the ASBE PTAC website. Their slides will be posted there after the public meeting as well. Presenting first, we have Dr. Christopher Chen, who is the Chief Executive Officer of ChenMed. Welcome, and please begin, Chris.
Thank you very much. Sorry I couldn't be there in person. Well, my name is Chris Chen. I'm a primary care doc and cardiologist. I'm also the CEO of ChenMed, and we're family-owned. And unlike any other type of practice that's out there, but I believe that our model should be much more universal, much more global. ChenMed began in the 1980s, and we had this mission that we wanted to serve. We weren't trying to chase investor returns, but by having mastered and standardized what we do, we've actually surprisingly self-funded all of our growth. We now, by the end of the year, should be operating about 130 medical centers across 3 brand names, hitting roughly 40 cities and about 14 states. As of this week, I believe we're going to break 5,000 employees. And on average, we've been growing about close to 40% per year. Our background is risk. We believe that we are, like many people in the room, a pioneer in risk, in that we work 100% in a global risk model. And, we're fully accountable for the total cost of care. That means on the spectrum of risk, there's, fee for service, then there's that small proportional jump into value. And then you start to move down that sort of, slope towards the very far end of that risk spectrum. And that's where we are, where we hold full upside and full downside, even stop loss, A, B, and D, all costs. And historically, we have operated in Medicare Advantage because it was really well suited and structured for the type of care that we give in a risk-adjusted global capitation model, especially in the populations that we serve, which I'll talk about shortly. However, we too have recently applied to participate in the ACO REACH demonstration model. Just saw Liz there, so excited that she had an opportunity to speak. And so we can now take this model that is able to achieve the kind of outcomes that I'm going to be sharing with you to not just Medicare Advantage patients, but also Medicare patients. ChenMed has a focus. We serve lower income seniors with multiple chronic conditions. And we have a mission-driven model of love, accountability, and passion that compels us to serve those whom our healthcare system has essentially overlooked, forgotten, and ignored. By focusing on this target population, we've become experts in their needs, and we've actually designed a care team or a care system for them. Let me just give you some demographic numbers. Our patients are about 40% dual eligibles. 70% of our patients are racially or ethnically diverse. I've heard most recently that over 70% of our team, of our care team, are women of color, believe it or not. Our patients typically have 5 or more major chronic conditions. And our senior medical centers are actually located in the most underserved neighborhoods where our patients live. So we have boots on the ground. And these are often the patients that make up a large share of the total cost in the overall Medicare population. We're very familiar with that 5% that accounts for 45 to 50% of the cost, or 15% that may account for 70 to 80% of the cost. Those are our patients. But I strongly believe that the method that we call transformative primary care can translate beyond our target population, and it can benefit the broader American population. So let me just share with you what we consider our model and what we consider what transformative primary care is. So how does ChenMed work, and what does it imply about our policies that can spur others to work similarly? We need more people joining us in the way that we do things. So here are some differences. We believe there's what we call type 1 traditional primary care. In short, this is a narrow and reactive primary care model where primary care doctors do not have accountability, and they are rushed to do some wellness visits and mostly churn through their sick visits, trying to triage patients downstream to the right specialist, which are typically pills, procedures, and referrals. And they're used as a tool within large health systems to actually help to generate those downstream that downstream volume. The problem is it doesn't solve health. If you have more of that primary care, you're going to solve health, and it will not lower costs. Evidence has demonstrated that. And it doesn't address the whole person, the physical, the mental, the social. Then there's type 2 primary care. We call that advanced primary care. Now, this is worlds better. Now, the financial accountability through taking capitation is there to varying degrees, but the strategies employed are sort of wraparound to the PCPs that are going after the finances. So let me tell you what I mean. It's sort of like financial measures. These are, advanced primary care groups out there that their primary goal is to chase after risk adjustment, squeezing the downstream providers, whipping them for costs and for pricing, using third-party vendors a lot. And in that environment, actually results do improve. You get better outcomes and you do get some lower costs. But the issue is there are complaints and from patients. There's potential for malalignment between patient and provider. And then there's also incomplete realization of true goals. What I'd like to introduce you today is what we call type 3 transformative primary care, which we believe we are helping to create and pioneer and lead in the U.S. today. And this is where there's this true, proactive, holistic clinical model. See, it's the same, economic structure as the previous advanced primary care type 2 model, but the solutions come through the PCP. The accurate risk picture comes through the PCP's deep patient engagement. Our PCPs, believe it or not, spend about 9 to 12 months training and learning to lead teams, influence patients, master customer service, understand medical economics, differentiate documentation and care for outcomes versus for billing and more. And we actually train our doctors differently. We don't joke anymore. We actually tell them seriously, doctor, when you join, it's a 1-year fellowship. Do not think of this as you're an attending. You are a well-paid fellowship, right? And we put them through this training. And let me tell you the 3 things that we focus very deeply on, and which we think we are helping to forward the field of medicine and training in. So 3 areas. Number 1, we train doctors to think holistically. Historically, PCPs have solved problems through pills, procedures, and referrals. We have learned that about 20% of a true patient's health involves pills, procedures, and referrals, what we learned in training. The other 80% of the equation is moving most of these patients upstream to focus on things that, for example, are lifestyles and behaviors, social determinants of care. And of course, we have not yet figured out a way to modify genetics yet, but maybe one day. And so as doctors, as we think holistically and training doctors to think holistically, that is something that we must sort of develop in our physicians. Second of all, we train our doctors to focus on prevention. Now, Paul, I know you're at New York Presbyterian. I'm a doc. I finished my training at a Harvard hospital, and then I went to Cornell and felt very good about myself. Came to South Florida with the equivalent of 5 board certifications. You can ask Bruce Lerman if he thought I did a good job. I think he still thinks very highly of me. And but what was crazy was my very first patient was a heart failure patient. And I said, I got this. And that patient got readmitted and died. And so I discovered very quickly that I did not know, that doctors do not know, they are not trained in prevention. For something as simple as heart failure, in which I'm probably, at the time, was one of the highest trained cardiologists in the state at the time, who did not know how to prevent what, quite frankly, is one of the most preventable and leading causes of admission in America today. We believe today that 90% of heart failure admissions are preventable. Talk to any emergency room doctor. They'll give you the similar number, 80 to 90%. And we've demonstrated that, particularly in patients with multiple chronic conditions. So we are training doctors to move upstream. We are creating workflows that do not exist. We have evidence, we have data that surpasses many of the academic institutions that I've worked at, because we are so broadly distributed and because we have access to the full source of all the data sets to create these workflows in prevention. And third, we train doctors how to win. What I've discovered is that doctors, during our training process, we're not taught to be accountable for outcomes. We're altruistic people that are mission driven. It's a calling. But yet we aren't taught how to win. We are taught and we come in wanting to win, but not taught how to win. And the only way that you know if you're winning or not is you have to measure it. So we actually make our PCPs accountable for an outcome. We expect our PCPs to reduce hospitalizations by 50%. It is not enough to try. We do not give out trophies for trying. We are unique in that we give trophies for winning. And therefore, we believe that we, our doctors, are accountable for improving the patient's health outcome across the spectrum, because you cannot improve what you do not measure. And so we measure everything. Where you have folks with several analytics people. In our organization, we have well over 300, it would be close to 400 data scientists and software engineers in our organization that's partnered with us. And so we take our tech and we take our analytics very, very seriously. So what is our care model? It's very simple. If you just take concierge medicine and you put it on steroids, you got it. So our PCPs have very small patient panels, typically about 400 to 1. Concierge is typically 600 to 1. In our neighborhoods, it's typically 3,000 to 1 because they're deeply underserved, right? High deprivation indexes. And this allows the PCP to have a deep relationship where we see our patients monthly at a minimum to manage their complex diseases. And our doctors, they are surrounded with a care team, and they give their patients their cell phone numbers. And then we give them a whole host of capabilities in terms of case managers, care coordinators, care promoters, pharmacy services, and we wrap around that PCP, but the PCP leads the team. We believe that we are the largest physician leadership organization in the country. And so we believe that the most important element to our PCP success is to learn to give patient trust. You cannot modify behavior and move upstream without earning patient trust. So the way we do this is with these frequent visits, with these cell phone, giving away your cell phone number, with meeting with the families, wrapping around in the home. And it's not just the PCP and their care team, but the care team reports to the PCP. PCP is ultimately accountable. And so we are focused and aligned with the patient in creating a plan, a very customized plan with that patient, with all these resources to improve health that ultimately reduce hospitalization rates. Another highlight is a deep investment in overcoming social determinants of health. We offer door-to-doctor transportation through our MA benefits. We work with plans to do that, so our doctors can come to us immediately, anytime, during office hours. And in the off hours, we have different resources depending on the markets that we're in, given that we're in so many cities. We provide on-site labs, draws. We do on-site medication dispensing for 85 to 90% of our medications. We have all tier 1 specialties on site. We have diabetic resources. We do cooking classes, social classes, Zumba classes, Tai Chi classes to reduce hip fractures and falls, you name it. And we do that in addition, and we marry those resources with end-to-end purpose-built technology developed specifically for outcomes, not the increased revenues and billing. That is not the goal. We have our own EMR. So that's very unique. And then we develop our workflows in that EMR. ChenMed is a primary care company, but we're responsible for everything. Therefore, if a ChenMed patient needs care beyond what we can offer within our employed primary care staff and our tier 1 specialists, then the PCP remains the quarterback, no matter where they go. And again, we have these central analytics teams that they partner with our patients to focus people through more high-value, better outcome specialists. We are tracking this data, and we are tracking who follows evidence-based medicine, because we even have central specialty centers of expertise within our organization. But the key point is the patient remains our patient regardless of where they go. We are fully accountable for everything that happens no matter where the patient goes, and their financial model supports that. ChenMed brings light to the darkness. Just want to wrap up with this final point here. What we do matters in our communities at large, because when we treat our senior patients and their health outcomes, it benefits their families, because so often our patients are the caregivers, the grandmas or the grandpas that are watching grandchildren. So their children who are 75% of the time single moms, can go and work their one or many times 2 jobs. So if we can uphold the senior population in these neighborhoods that we serve, we actually don't just serve the health of the patient, but we transform the health of the community, because these are the individuals that are the pillars of the health of the community. So let me just talk some data, because we like that. We talked about a 30 to 50% lower hospitalization rate. We do the same for ER visits. Our screening rates are much higher than national averages, and that's where the average is much higher. We have care programs that have, and we've published that we can reduce stroke rates by 22%. We have reduced heart failure admissions by over 70%. We believe that we have data that supports that our patients, when they develop cancer, have a 50% 6-month mortality compared to patients who are not ours prior to joining us with cancer. So pretty cool numbers, we believe, and we're going through data right now, but not only do our patients, and many times, we are equalizing their outcomes between our Black and our white patients and our duals and non-duals patients. We believe we're equalizing that. In many cases, we are even eclipsing the average Medicare recipient, and even in higher income outcomes, because they are patient focused and outcomes focused. Our patient satisfaction numbers are in the 90s, as you can imagine, concierge medicine for the lowest income people, and with net promoter score in the 80s. So here's some simple suggestions. Number one, I believe we must push global risk. That's two-sided. Partial cap does not work. People will not change their behaviors. They will wrap around things to get their outcomes. Number two, we must protect and enhance risk adjustment, not kill it. You got to take away the incentive to pick a perfect population, and doctors can do that. We've seen that in the past. So you need risk adjustment. Otherwise, people will not go and take care of the sickest population. But how do you prevent the gaming? You have to rely on people who are closest and most accountable for the care. So we believe that PCPs should be the ones who are risk adjusting. We do not believe that you should be able to hire third parties and wrap around services and go to the home to just diagnose people and not participate in actually transforming their care. And we must put that risk with primary care. And we must come up with solutions that can fundamentally change tech and how we do tech. And we believe that health equity is best solved locally, not across the board. And that's it. Thank you very much for your time.
Thank you so much, Dr. Chen, for that very interesting presentation. We are saving all questions from the committee until the end of all presentations. Next, I'm honored to announce we'll be having a joint presentation from Dr. Palav Babaria, Chief Quality Officer and Deputy Director of Quality and Population Health Management at the California Department of Healthcare Services, and Mr. Paul Leon, founder, CEO, and president of the Illumination Foundation. Please go ahead.
Thank you so much. Hi, everyone. It's a pleasure to be here with you today and to share some of what we are doing in our California State Medicaid program, also known as Medi-Cal. I am an internist by training and have spent most of my career working in value-based payment and clinical operations on the healthcare delivery system side, mostly in California's safety net, and joined the department a year ago to really lead our work around value-based payment, quality, health equity, and population health management, especially given the tremendous changes happening across our program right now through the CalAIM initiative. We can go to the next slide. So to provide a little bit of context, we're going to kick off with what we are doing right now to really think about whole person care for our members that really touches upon a lot of the same themes that Dr. Chen touched upon, thinking about how do we provide integrated upstream care that really gets at the root drivers of our members' needs. We can go to the next slide. So for those of you who are not enmeshed in the California Medi-Cal landscape, we, the California Department of Healthcare Services, launched CalAIM, which is really a multi-year transformational initiative to fundamentally change how our state Medicaid program operates and achieve a few really critical goals. We are a very large state. We have 58 different counties, very different populations and regions across those counties. And we have significant social drivers of health that day in and day out impact the outcomes of all of our members in the Medi-Cal program. CalAIM really seeks to identify and manage member risk through this whole person care approach and really addressing the social drivers of health as a key part of our Medi-Cal program. We also have a lot of variation across the state. So a lot of the initiatives in CalAIM seek to provide a consistent and seamless experience and standardize many of our fundamental program components across the state of California. And then most importantly, all of the initiatives in CalAIM are geared towards improving quality outcomes, reducing health disparities, and driving delivery system transformation through value-based payment. We can go to the next slide. So a little bit of background and context. The two initiatives that wanted to highlight that are part of a much broader suite of initiatives that comprise CalAIM are enhanced care management and community supports. The issues that enhanced care management and community supports are designed to address is that we know over half of all of our Medi-Cal spending is attributable to 5% of enrollees with the highest cost needs. We also know that our Medi-Cal enrollees have often multiple complex health and behavioral health conditions. And we also know that across the state, these enrollees have to engage in multiple different delivery systems. They access most of their physical health through our managed care delivery system. Our behavioral health system is carved out and operated at the county level. So for anyone with severe mental illness or substance use disorder needs, it is an entirely different delivery system that may or may not be effectively integrated and coordinating with their physical health needs. Dental is similarly a carve out, and then there is numerous local county-based programs that provide care management and county coordination, care coordination as well. You can go to the next slide. So both enhanced care management and community supports, which we are currently in the process of scaling statewide, were really informed by previous tests of change under largely our previous Section 1115 waiver programs. The whole person care pilots and the health home programs pilots really looked at, how do we take these very complicated, high utilizer individuals and create an effective suite of wraparound services that will change their health outcomes. The initial evaluation, which is not finalized yet, showed really remarkable results in this domain. So from the beginning point of the whole person care pilot to our mid-year evaluation, enrollees who reported being in excellent or very good overall health increased from 8% to 22%. There were more modest improvements in emotional health. The number of enrollees ages 18 to 59 who had controlled blood pressure went from 36% at baseline to 65% after enrollment in this program. And there were also modest increases in the number of enrollees with controlled blood pressure rates. The changes on total cost of care and especially readmissions, ED visits and hospitalizations was a little bit more mixed. Not surprisingly, a lot of those changes were delayed in seeing those outcomes after enrollees were established in their care management programs. So the experience from those pilots that occurred in numerous different geographies and populations across the states led to the creation of enhanced care management. Enhanced care management is a new Medi-Cal benefit and is a new managed care contract requirement that is available to all of our enrollees in managed care who meet certain criteria. And the care management is provided through community providers, and they essentially become the lead care manager who will coordinate that member's needs across delivery systems, across local social services entities, housing entities, to really provide the whole person care, not just for their healthcare needs, but also linkage to addressing all of their social drivers of health. In addition, community supports are currently optional services that they are strongly encouraged, and Medi-Cal plans have been slowly scaling up the number of community supports that they provide. They're really focused on, providing in lieu of services that we know can reduce the hospital length of stay, prevent avoidable readmissions, and hospitalizations. We can go to the next slide. So to just provide a little bit more detail, so for ECM, this is really, as I mentioned, designed to provide comprehensive wraparound care management for any enrollees that have complex needs, and really navigate those enrollees across all of the different delivery systems that can be fragmented and very challenging for our members to navigate. And they are designed to address both the clinical and non-clinical needs of these high-need enrollees. We can go to the next slide. Community supports are really services, as mentioned, that are designed to be in lieu of other types of healthcare utilization that is often higher cost with lower value when we look at the quality outcomes. So I'm not going to read all of these, but these are the suite of community supports that in current state are not offered statewide, but each managed care plan based off of local needs and capacity is starting with a few of these and then looking to scale over time. We can go to the next slide. I think I'm turning it over to Paul. So hopefully that brief overview of what the state is doing around enhanced care management and community supports will provide the context that is needed to understand what Paul and his team have been doing at the local level and the impact that these programs have for our Medi-Cal beneficiaries on the ground.
Thank you, Bava. Happy to be here. My name is Paul Leon. I am a public health nurse by trade and CEO of Illumination Foundation. We are a grassroots nonprofit that we're a provider in Southern California, Los Angeles, Orange County, and Inland Empire. So back in 2007, straight out of NBA school, we walked into, actually it was a class project, walked into this shelter in Orange County and realized that at this shelter, there was about 200 children, families, individuals with mental health, substance abuse, and realized that we had to take care of this population. At that time, there was about 6,000 to 7,000 rough sleepers, people that were staying in the streets of Orange County. As you know, Los Angeles now is the epicenter for homeless and unstably housed, so we migrated it up into LA. We currently are the largest medical respite recuperative care in the nation. We have 408 beds. We get discharges directly from the hospital, police, county, and we can self-refer now. The Fullerton site up in the left is our flagship site. It actually has a shelter on the bottom, medical respite, and on top services, primary care, dental, psychiatric, housing navigation, and workforce. All the services are on the top, and on the bottom it's a navigation center and a shelter. It also has it's a full service area that individuals could stay there. Our newest site is UCLA. You'll see on the bottom, and it's actually a medical respite that is within the hospital. So that is kind of the trend now for medical respites, to partner with the hospital and place them either adjacent to the hospital or in a facility near the hospital. So what we realized early on, we started 15 years ago, is that not only did you need a central location, which we call a hub, and that's a medical respite, but also you needed to discharge individuals from that facility. They're not quite ready to go to another facility, so we actually transfer them to micro communities. You can see there we have I think about 241 different micro communities, some that are mental health, substance abuse, some a lot more for seniors now, and couples. These are the micro communities. Again, 241 doors. They're in the community adjacent to the medical respite. So this is our model, and it's basically street to home. We have individuals that are homeless, and now we're seeing a lot more individuals that are just unstably housed. They lost their housing, and from month to month, they're staying at different places, couch surfing, going back with their parents, going back with their kids, either way. So this is the model that we developed early on. It's the ability to take somebody from the street to either a navigation center, a family emergency center, and you'll see medical respite recuperative care is in the center. and then into micro-community and permanent housing. Prior to CalAIM, we figured out how to fund this through city grants, through different organizations and hospitals that would pay for medical respite with charity dollars. And then, of course, when we're able to get individuals into housing, HUD would pick up and we'd pay with it for vouchers. So that was our continuum of payment until CalAIM came. And when CalAIM was initiated, it now funds pretty much all this process. A little bit about the data and some of the clients that we see. We do both predictive and prescriptive analytics, but you can see that the population, like Dr. Chen was talking about, that we see are high risk, high score risks that we use the HCC predictive model from CMS. And you can see that we have 245 of these clients that we got the information from our CalOptum, our CMO, that have 10 or more distinctive diagnoses. Most of our clients have mental health plus medical health that we're taking care of. This is just another breakdown of the scores that we're seeing, more of a visual of clients that you can see run the whole gamut of risk. So one of the things that we started to really realize, and we did this early on, but we didn't call them social determinants of health. We realized that it was not just the medical things that they were coming to us for. A lot of them was, somebody would come to us with a broken leg or a wound. However, they had no transportation. They couldn't pick up their medication. They couldn't do follow-up with the hospital. So we really started to focus on and do a lot of the AI work and really drill down so we could do prescriptive analytics and really drill down on social determinants of health. And you'll see, I believe it's the next slide, but one of the really incredible benefits from medical respite, you could see how many individuals weren't connected to a primary care physician. And now, then they came into our program, we were able to connect them to their primary care physician. Obviously, the savings are immediate when you can curb the ED utilization and hospitalization. You could see right from the start, we were able to enter these patients into medical respite and then provide most of the care on site or by one of our local FQHCs. One of the things that we found out when we started really analyzing the data, we had years of data, but we never really scrubbed it, is that we actually were taking care of SBMI patients. We had no idea that there was that big a percentage of clients that were in medical respite. Normally, Beacon, our local provider, was admitting the mental health diagnosis for bipolar and schizophrenic. But within recuperative care, when we are with our clients and really could speak to them, they started to trust us, we realized that they were really multifocal patients with mental health and their medical diagnosis. One of the things, again, that data really showed us is the cost savings, and especially first year compared to the second year. And you can see that the obvious things that you can do when we bring our clients in, just basic teaching is going to save money right away. Things that transportation, basic needs, and especially housing, which is a component that CalAIM is starting to address. But you can see that if you stick with these social determinants of health, that the savings sometimes will come the year after. And again, this is just one of the graphics that we realized early on. This is data from our CMO clients, 1,266 clients. Their actual cost to CalOptum was almost $26 million. It went down when they came in medical respite, and then afterwards went up quite a bit because that's housing in there, but also medications were increased. We were really happy to see that. So overall savings for 1 year on 1,266 clients were $17 million.
And Dr. Babaria, we need to wrap up in about 2 more minutes.
Okay. And again, this is just some of the early projections for CalAIM. You can see that we've already implemented a lot of the parts of CalAIM, and it so far is really working well. We're able to see and now be able to get reimbursements for some of the things that we're doing that we really couldn't do it prior to that. And again, these are our monthly projections for CalAIM. And I'll just leave you with one last item is that, we had our last client that came in had actually lived in a cave for 12 years above LA, was working, living in a cave, and we entered her into our medical respite, and she has been there about 6 weeks and is doing really well. But that's the kind of clients that we're seeing with, a lot of unstable housing. So thank you.
Thanks, Paul. And I would just say, the local trends and complexity that Paul's describing is something that we've seen across the state in numerous of these community supports and enhanced care management programs that are serving our members. So hopefully that local context provides a little glimpse into what we're trying to accomplish. The one thing I did want to plant a seed with all of you is, as we've been doing this work and really focusing on our complex, high utilizer individuals, it has become abundantly clear that we also need to step back and take a long view of health and wellness. We can skip to the 3rd slide. There's information in here about how we're contextualizing our value-based payment work and all of these initiatives within our larger population health management strategy. But I'm going to pause this on this slide for a second. So as we've been looking at our programs, I think, as Dr. Chen mentioned, prevention and upstream intervention are not things that we naturally do well across the healthcare delivery system, or that, we physicians are particularly trained in addressing. I think one of our unique roles as a government payer is that we really can step back and take a longer view than sometimes our healthcare delivery system or managed care partners can. So when you think about our Medi-Cal program, we cover over 14 million individuals right now, or 1 in 3 Californians. But when you look at the younger populations, we cover about half of all births in the state of California and more than half of the children residing in the state. Then when we take our health equity lens, almost 3/4 of all Latino and Black children in the entire state of California are covered by the Medi-Cal program. And we know through extensive literature, research, trends in our own programs, and our work on adverse childhood experiences screening, that what happens to these children and pregnant individuals really determines what their long-term health outcomes were decades later.
I talked to 2 people on their end.
Sorry, is anyone else hearing that background noise?
You may want to mute whoever just joined.
So I think, just want to underscore that when we think about these complex populations and individuals, if we really want to address the number of high utilizers and individuals with poor health outcomes and multiple conditions that are in our nation, we really have to look upstream by decades. And government payers are really in a unique position to take this long view. We can go to the next slide. This just shows our Bold Goals initiative that we're launching to really think about this upstream intervention. And we are, rolling this out through all of the levers that we have across the Medi-Cal program, including in our value-based payment programs. We can go to the next slide. And I think where we're really trying to double down is, like many of the folks have talked about, how do we recenter primary care, and not just investing in primary care as it exists today, but really integrating it with upstream public health and social services programs that we know work and have a return on investment over the long run, especially home visiting. First Five associations have a number of models that are really working in the state of California. In addition to that, we are supporting investments in primary care transformation, and with our managed care reprocurement with new contracts going into effect in 2024, are also mandating reporting on the percent of spending on primary care as a percentage of total spend at the health plan level, with the plan to set targets for that spending in the future, as well as the percentage of alternative payment model arrangements for our health plans. So I just encourage us to really, think about where can we put in that long-term thinking and the long-term view, so that at some point in the future, we really are curbing the number of individuals that we need to enroll into programs like Paul's, as effective as they are.
Thank you so much, Dr.
Turn it over to questions.
And now at this point, we have a few moments to open up the floor for the committee members and for discussion and questions. So Dr. Chen, if you can also join, and I see Bruce has his hand raised. Bruce.
My question is for Dr. Chen. Doctor, what proportion of the entrance into that one-year fellowship that you mentioned actually make it through to the end? And would you say that there's a selection process that limits the number of primary care physicians who would thrive in your kind of system, or do you think there's a real upside to that?
What a fantastic question. It's only the number one thing that we focus on as an organization. So, if our job is to take primary care doctors and sort of deprogram fee-for-service from them and then retrain them in the ways that we just discussed, holistic care, preventative care, learning how to win, and lead. Not everybody can do that necessarily, right? So we spend an enormous amount of time, data, interviewing to figure out who are the primary care doctors that we believe can do this kind of care. Now, the good news is it's over 50%, what we've discovered. The number of people, I would say in our population, over 95, 97% of doctors get through the training program and do all right. But then you're saying that's because, Chris, you're doing a great job selecting, and we think we can do a better job. So I'll give you an example. I was on a panel once with a very prestigious organization, leader of one of those, and they were talking about their brand of the doctors that they're looking for, these amazing pedigrees and all the things that we talked about. And he's like, we don't hire these type of doctors. And I said, can you do me a favor? When you say no to those doctors, can you send them over to me? Because those are actually happen to be the profile of the doctor that I'm looking for. And it's outrageously counterintuitive. So doctors that can lead, doctors that can think holistically and move upstream, who can build relationships with their patients, they're very different than what typically medical schools and residency programs are looking for, and even prestigious organizations. It's just a very different profile. We actually psychologically profiled our doctors. We spent 5 hours doing that, capture all this data as we're interviewing them, and determine what are the types of doctors that can do this care. I'll give you a couple pearls of things that we look for that trump your pedigree, that trump your scores and everything else. Learning agility is absolutely critical. The speed at which they can learn. Because remember, we're telling them all the stuff that you've learned in the past may not help you as much in this model in the future. So learning agility is one thing. Second thing that has to go with learning agility is humility. Humility in different ways. Humility, A, to learn quickly, but humility also with the patient. So if there is this attitude that some doctors have, right, where with patients where they are, I am the authority and you are not, and you don't have to listen to me, and that's your problem. That unfortunately doesn't work well when you're building relationships with the patients and you're trying to get them to change their lifestyle behaviors and trying to get you to tell them the truth. You have to convince them to tell you when their son is stealing their Social Security check. So you can deal with that. right? These are fundamental real issues, and so you can only do that with trust. So you're right on. I believe that fee-for-service will be here to stay because I do think there is some proportion of the primary care work staff that is primarily designed for that volume-based type of care and shouldn't be accountable for outcomes. But the majority of primary care doctors out there, I believe, can make that switch and should make that switch. It's far more validating. We don't have a problem recruiting docs, by the way. There's a huge shortage, and we don't have that huge problem.
Thank you.
And then, Lee, next, I'd just like to give everyone a frame. We've got about 5 more minutes, so if you can make your questions succinct and answers succinct, there's a line of people who'd like to ask. Lee.
Yeah. Thanks so much. Dr. Chen, can you tell us more about your model's involvement with specialists, how you select them, how you contract with them, how you work with them inside your total cost of care type arrangements and philosophy?
So first of all, we are not based in California, so we do not have the ability to create our own delegated network here. And we're in so many cities. We're in 40 cities right now. So we can't hire specialists everywhere. However, I can tell you there are certain tier 1 specialists, obviously cardiology is one of them, endocrinology. There's certain ones that are in our population that are very common. And we will do our best to hire tier 1 specialists to come on site, either through a contract arrangement or through direct employment. We prefer direct employment so we can go through that training process that we discussed before and selection process. But then no matter what you do, you're going to have to work downstream with the local sort of ecosystem there. And you go to the health plan provider network, and then we start with that, and we start looking at data. We have blue button claims data. We have health plan data. They can share some of that with us, and we can look at some of their patterns. And we've developed algorithms across the board. We have these central specialists that sit in the corporate center that actually develop algorithms to say, are doctors following evidence-based care? And you can study that through claims data, believe it or not. That triangulates it, and then you got to sit there, and then you got to go visit those specialists and say, okay, are you the kind of doctors that want to collaborate on care, or do you just want us to send patients to you, but you never want to have a conversation? You don't want to collaborate. You don't want to coordinate. And if you're in the latter, sorry, we don't want to work with you. If you're in the former and you want to be a partner with us, and you're okay with us being the quarterback of that care, then you're a great partner, and we found the outcomes are the best. And that's essentially what we're looking for. We do not beat them up for costs, by the way. That's a unique thing. We do not beat them up for their rates. We prefer collaboration over rates every day. You get better outcomes at a lower cost.
And Walter, thank you. Walter.
Again, thank you for all the panelists for great presentations, very informative. Question for Dr. Chen, and you've kind of answered part of this with your answers to Bruce and Lee's questions, but it sounds like you have really engaged primary care doctors that you select through a very rigorous selection process. They give out their cell phones, they have small patient panels. But I'm wondering what kind of levers that ChenMed has post-training to really continue to engage and influence the PCPs to produce such great outcomes, 30 to 50% decrease in ER and hospitalization rates. I suspect some are financial, but both financial and non-financial.
So let me just handle the financial piece, because usually that's a big part of people's questions. Yeah, absolutely. We compensate for outcomes. And so that's number one. We give them, good compensation to begin with, and then we give them tremendous upside based on their outcomes. Number two, we are an overly transparent organization when it comes to those outcomes. Everybody knows how everybody else is doing. So you can imagine during the selection process, humility is very important, because if you're not comfortable working together and sharing data together and all talking about it together, this is not the place for you. So we're outrageously transparent across even markets at outcomes. The doctor sitting next to you, you know exactly how they're doing, you know how you're doing, and you're learning from each other. So it's not a shaming concept. It is a team type of aspect. Remember, love, accountability, and passion. Last but not least, we allow doctors to grow. Doctors, they end of their job and they're like, I've reached my ceiling. This is what I'm going to be doing. I'm going to sit in a room and see patients for the rest of my lives. And we're saying maybe, but there's a tremendous opportunity to grow and lead. And so we've developed a development path for doctors to grow in our organization in dramatic ways. And it's not unusual for doctors to get promoted every 1-2 years into new roles and new leadership roles, either clinical leadership roles, administrative leadership roles, teaching, selection. Just remember, physicians are such a fabric of our operating model, and we pair them with business leaders. So we need doctors to get promoted. And so they get that opportunity. And then they get recognized by their peers and by other folks and, testify at Congress and whatnot. So that becomes exciting for them.
And Angela, I saw you had your tent up.
Lee asked the question I was going to ask. So.
Excellent.
Good.
So for Dr. Babaria and Mr. Leon, can you speak to the criteria for determining which patients are appropriate for community supports in enhanced care management, and also what kind of crossover you see with the senior populations when you think about Medicare, if you could speak to those two things?
I'm happy to start us off at the state level, and then Paul, you probably have more details at the local level. So for enhanced care management, we have specific populations of focus that were really informed by those whole person care and health homes pilots, targeting individuals who are homeless, have severe mental illness, substance use disorders, usually with other criteria such as ED visits, hospitalizations, or chronic conditions. We are still working on our policy and rolling out that benefit for justice-involved populations as well as children and youth, and still finalizing the criteria, as well as for long-term care and individuals residing in the community but who meet long-term criteria of care. So more to come in that space in the year to come. And then for community supports, it's really, anywhere based off the recommendation of the provider, anywhere where that benefit would thought to be beneficial. So there's a broader application, and we will be doing a thorough evaluation to really assess the efficacy of that approach and what the impact is on both health outcomes and total cost of care.
Yeah, and for us, medical respite, they're referred to usually by the hospitals. Now, because of CalAIM, we can self-refer, but many of the plans and providers aren't really sure where their clients are. And they give us a list each month, and we go through, find their clients with outreach. And as far as seniors, it's the fastest growing population of homeless and unstably housed. So many of the plans, for example, Kaiser, they want us to find maybe grandmother who's staying with 2 different daughters, and will just pop up in the ER, and they won't really know where where their client's at or their patient. So we will enroll them in ECM and then make sure that we can navigate their primary care physician.
And I should just add.
Oh, go ahead.
I was just going to say on the seniors front, definitely underscore everything that Paul said, that in almost all of these categories, we are seeing the impact of all of these chronic conditions, the housing crisis in California on seniors. And so we have a separate work stream specifically focused on duals in our program. And that is absolutely where we see a large burden of all of these issues.
Jennifer.
Thank you for the wonderful presentations. My question is for Dr. Chen. We heard yesterday about participation and incentivizing providers, physicians in particular, in programs and outcomes. What percentage of your physicians' total compensation is incentive comp?
I mentioned that we had multiple layers, right? And doctors have tremendous opportunity to grow. So we bring them in with a base that is essentially highly competitive with their market. That's usually the starting point. And then we usually put about an additional 20 to 30% opportunity on top of that. That's at the base PCP level. As you start to, if you will, move up the ranks and demonstrate that you are successful in this model and you can continue to teach or even develop workflows or do research that helps us drive towards better outcomes. What we mostly flex in that environment is usually based on outcomes, and it's going to be the variable component. So you could have a doctor at one point getting an additional, 50% of their compensation could be entirely variable, and all the way to the very top, where you have folks where perhaps even 2/3 of their compensation is based on outcomes. So hope that helps.
Thank you. And one final question for Dr. Babaria. Can you speak very briefly to multi-payer alignment that's happening with HIP in the state? There's a lot of interest in the group, but a brief answer, and then we'll go to break.
Absolutely. So at the state level, we have a collaboration between Medi-Cal, which covers about 1/3 of our population, Covered California, which is our incredibly robust state healthcare exchange, and CalPERS, which is our sort of state employee and retirees benefit system. So collectively between us, we cover upwards of 42% of the entire population of the state. So us 3 state purchasers have an ongoing strong relationship and collaborative to align all of our measures, where possible, really, support that downstream alternative payment model in a coordinated fashion, and are participating in the HCP Land State Transformation Collaborative so that we can really scale some of those efforts statewide with primary care practices.
We want to thank you all very much for joining. At this time, we're going to take a short break until 10:45 Eastern. Please join us then. We have a great lineup for our roundtable panel discussion. Thank you so much.
Produced by the U.S. Department of Health and Human Services.